This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from the University of Texas MD Anderson Cancer Center, recently published in the Journal of Neuro-Oncology. It's titled Intraoperative Technological Advances and New Frontiers in Precision Glioma Surgery.
This is a timely review, Ilara. We all know that diffuse gliomas are among our most challenging cases. Their infiltrative nature and proximity to eloquent structures make maximal safe resection a moving target. The authors highlight that while the standard of care remains surgical resection, followed by the STUP protocol, radiotherapy, and temozolomide, the 5-year survival rate is still stuck at around 10%.
Exactly. And the paper starts by revisiting the core of our surgical philosophy, the relationship between extent of resection, or EOR, and survival. While some studies suggest we need at least a 70 to 78% resection for a survival advantage, there's a massive push now toward supramarginal resection.
Right. Moving beyond just the contrast-enhancing tumor on T1 into the flare hyperintense regions. The paper mentions that achieving more than 20% supramarginal resection significantly improves overall survival, independent of age. Even the RANO-RESET group found that leaving less than 5 cubic centimeters of non-enhancing tumor was better than just removing the enhancing core.
But there's a catch. The paper is very clear that aggressive resection in eloquent areas can be a double-edged sword. Any benefit from a 95% EOR is basically negated if the patient wakes up with a new neurological deficit. That's why the study focuses so heavily on the tools we use to navigate this maximal safe boundary.
Let's dive into those tools. They start with the gold standard for eloquent cortex, awake craniotomy with direct electrical stimulation. It's still the best way to map subcortical tracts and reduce postoperative deficits. But moving into the more modern tech, what do the authors say about the synergy between fluorescence and imaging?
This was a key point. They discussed 5-ALA and fluorescein, noting that their combined use achieves a greater EOR than either agent alone. But even better is the combination of 5-ALA with intraoperative MRI. The MRI is crucial because it compensates for brain shift, that progressive displacement of tissue as we remove tumor and CSF, which can make our initial neuronavigation inaccurate. Together, 5-ALA and MRI provide the strongest platform we currently have for maximizing safe resection.
I also noticed they spent a good deal of time on tissue characterization. We're moving away from just looking at tissue and moving toward real-time molecular diagnosis.
Yes, they highlighted stimulated Raman histology, or SRH, and confocal laser endomicroscopy. But the really exciting stuff is the AI-based platforms like Fast Glioma and Deep Glioma. These allow for rapid intraoperative molecular diagnosis without the traditional delays of a frozen section. Imagine knowing the molecular subtype while the patient is still on the table.
That brings us to the new frontiers section of the paper, which covers the second clinical imperative, enhancing local therapeutic delivery. We know the blood-brain barrier, or BBB, is our biggest hurdle. Even though it's structurally compromised in high-grade gliomas, it's still restrictive enough to block most systemic therapies.
The paper outlines several ways we are now trying to bypass or disrupt that barrier intraoperatively. One is low-frequency focused ultrasound, or FUS. It uses acoustic energy to temporarily open the BBB, allowing for high local drug concentrations.
And then there's convection-enhanced delivery, CED. Instead of relying on diffusion, which is slow, CED uses a pressure gradient to distribute therapeutics directly into the brain parenchyma.
They also mentioned an approach that I think residents should pay close attention to, endovascular intraarterial infusion. By using the tumor's own vascular territory, we can deliver targeted therapy across the blood-tumor barrier more effectively than systemic IV.
Let's talk about the resection cavity itself. Once the tumor is out, we have this window of opportunity. The authors discuss photodynamic and sonodynamic therapy, generating localized cytotoxic effects right there in the cavity. But I was particularly interested in the cesium-131 tile implants.
The intraoperative brachytherapy. The study notes that these cesium-131 tiles deliver conformal radiation at the time of resection. What's fascinating is that they might actually potentiate anti-tumor immunity, not just kill cells through radiation.
And we can't forget LIT, laser interstitial thermal therapy. The paper frames it not just as a cytoreductive tool, but as a way to create a therapeutic window. The heat from the laser causes sustained BBB disruption for several weeks, which allows us to get otherwise CNS impermeant agents like checkpoint inhibitors into the target area.
It's really a shift in how we view the surgery. It's not just debulking anymore. It's a phase-organized intraoperative workflow. The paper breaks it down into preoperative planning, real-time resection guidance, intraoperative tissue assessment, and finally, post-resection local regional delivery.
That's a great summary, Ilara. The conclusion of the paper really hammers home that the future of precision glioma surgery isn't just one of these tools. It's the deliberate integration of all of them. We need prospective validation of these combinatorial strategies to really see if they move the needle on survival.
It definitely feels like we're entering a new era where the OR is becoming a laboratory for real-time precision medicine.
Absolutely. Well, that's all the time we have for today's deep dive. For our residents and colleagues, I highly recommend reading the full text in the Journal of Neuro-Oncology to see the specific data on these AI platforms and delivery systems.
Thanks for joining us on the Neurosurgery Hub podcast. We'll see you in the next episode.
Until next time.